Dr. Wendi, thank you so much for joining us on the Allsorts Pod. I've really been loving everything that you're sharing on Instagram and TikTok, and so excited to learn more about IBS with you.
Absolutely. Thanks so much for having me.
So I'm curious to ask you how you decided to A, become a physician, but B, go into gastroenterology, because gastroenterology was definitely not on my radar as a young person, and now is like a gastro RD. I was like, wow, I wish I had known a lot more about this stuff before I got started. So did you have physicians in the family? What's your doctor origin story?
My doctor origin story is actually the opposite. So my older sister is a physician. And because she was a physician, my parents decided, oh, we don't need another doctor. How about you become a lawyer or like an engineer or something else? And so I studied economics in college. I had no intention of going to medical school. I actually worked for a few years in business and realized, oh, actually, I do want to do what my older sister's doing as much as I resisted that. So ended up applying to med school. And then with GI specifically, I think even from the days of high school biology, I always found the digestive system so fascinating, so interesting. And I think part of that is as a foodie, I think I always thought about how, oh, now I can understand the physiology of things.
Yeah.
Um, and then with GI, I think there's so many patients out there where they have such a complicated relationship with food. And so something that's really important to me is to get my patients enjoying the food that they eat and with as little symptoms as possible. So I think that's a really big reason, as somebody who loves food, being able to share that with my patients and get them to enjoy their food as well is important to me.
That perspective is so incredible. And I would love to maybe dig into that a little bit deeper, because as a dietitian, and over the last 15 years, so much has changed. But definitely early on in my career, I encountered a lot of patients whose gastroenterologists were just nutrition doesn't matter, just eat well when well. And seeing them go down these rabbit holes of confusion and fear of food. Was it that you were a foodie first, and so that has just informed your practice and sort of your passion for those two things together? Or was there something in your education or in your practice where you're like, wow, I'm seeing how this is affecting my patients, and I really want to make sure that we talk about this?
Oh, I don't know which came first. It's almost the chicken or the egg. But I would say that in my practice and the people that I've learned from and the experts that I've learned from, I think a big thing that I started realizing was a lot of kind of the traditional medicine that we prescribe is, as you said, try to exclude FODMAPs or try to avoid your triggers. And the thing I find is most patients have an overly restrictive diet. And so I think that that's where the foodie side of me comes in, that I think food plays such an important role in our lives beyond just nutrition, but I think it's part of our social life and it's how we interact with people and it brings us pleasure just purely because we enjoy to eat. And so I think that's a really important thing that I, as a person, resonate with, and I want to make sure my patients don't miss out on that part of their lives. But I think
And
the data and the evidence supports that entirely.
yeah. And what a gift to be able to have someone like you as their gastroenterologist, particularly with what we're going to talk about today, irritable bowel syndrome. I find, as someone with IBS myself, but just being in this space, there is still so much misinformation and there's so much fear of
Hmm.
food, which, makes intuitive sense on the part of the patient, because if they eat food and then experience symptoms,
Hmm.
they're instantly like, well, what did I eat? What did I eat that
Right.
made me feel bad? And if I take this out, maybe it'll work. And sometimes,
Hmm.
restricting your diet a little bit does work at first. And then you're like, oh, wow, I feel bad again a week later or a month later. And then you look for something else to restrict.
Yeah, and I think that's part of the control aspect as well. Like having a condition like IBS is just so hard, can be so, makes it a big impact on your life. And so trying to take that control back, oh, maybe I can make my symptoms better because of by, limiting my food or avoiding this. But I think a lot of what I find is food itself can trigger symptoms as opposed to specific food. And we can't not eat food at all. So I think a lot of what I try to address is trying to find out if there's a specific food or if it's food in general, and then that can affect my treatment approach.
And that is such an important distinction to make. And I don't know if people will sort of like zero in on the subtlety there, that you can have a trigger food, like say in
Hmm.
FODMAP intolerance, maybe fructans and wheat are your trigger food versus
Hmm.
just the presence of any food in general in an irritated, overreactive gut.
Exactly. And so something I always tell patients to do is really think about, is it that you're always experiencing symptoms with this particular food? Or is it that sometimes you're experiencing symptoms with this food, but not all the time? And then that can help make that distinction, whether it's food in general or a specific food.
Yeah. So maybe at this point, we should dive into sort of the foundation here and talk about, because I still think, at least amongst, I mean, even some practitioners, but even definitely amongst the general population, a confusion about like, what is irritable bowel syndrome actually?
And I think there's a lot of confusion even amongst physicians themselves, and especially non-GI physicians.
Yeah.
So, irritable bowel syndrome is a condition that's part of a bigger family of conditions called disorders of gut-brain interaction. And really, the issue here, as I explain to my patients, is there's some sort of communication issue between your brain and your gut. And it could mean that your gut is sending abnormal signals to your brain, telling your brain, I'm hurting, I'm hurting. Or it may be that your brain is sending incorrect signals to your gut and telling your gut, slow down, or speed up. So it can affect your gut in multiple ways. So in IBS, I think of it as affecting both the motility, so the speed that your gut moves. So that can cause diarrhea or constipation or both, or as well as a pain processing issues. So hypersensitivity. So things that someone without IBS might find, they might not even feel, such as stool in the colon or just normal peristalsis, can be very excruciatingly painful for someone with IBS. And it's all related to the signaling.
Yeah. And this is, such an important thing to clarify, that there are very real changes in that gut brain. Because, back in the day, I hope no one would ever hear this in 2024, but like back in the day, because, you know, upon normal examination, things look, it's not celiac disease, it's not Crohn's
Right.
disease, right? And so you had this, sort of trope of people being told these symptoms are in your head, but there are very
Hmm.
real changes in the nervous system in the gut.
Absolutely. And I think I always make a big distinction with people. It's not in your head. There's a miscommunication. So it's a nerve problem. And I think a lot of things that other people hear and many patients hear is that, oh, it's your anxiety causing your IBS, or it's depression causing IBS. And they are definitely related conditions. Their risk, like having depression and anxiety, is a risk factor for developing IBS, but it's not your a manifestation of your depression or anxiety. There is an actual pathophysiological mechanism that's going on here.
Yeah. So maybe let's talk about that a little bit. What are some of the risk factors for, getting IBS, and like, why do we get it? Like, what do we know about the pathophysiology of it?
Yeah, so I think a lot of it's like thinking back to what could cause the nerves of your gut to misfire, or what could cause alterations in the pain processing and your motility of your brain. And so things like the gut microbiome definitely play a big role. We definitely see changes in the gut microbiome with patients with IBS. I think we're still in the infancy of knowing what to do about that and how we treat that. And whether it's, again, chicken or egg. Is it because you have IBS that your microbiome is altered, or is it because your microbiome is altered that you have IBS? So that's still a relationship we're trying to tease out. Other risk factors, I mentioned depression and anxiety, and many of the neurotransmitters that play a role in depression and anxiety have a similar signaling role in our gut. So we know that there's a relationship there. And then having another pain processing condition. So something like fibromyalgia or migraine headaches, those are all risk factors for developing IBS. And then lastly, there's a strong family history component to developing IBS. So something I always ask my patients is, is anyone else in your family, do they also have a sensitive stomach? And often I find that that's pretty common there as well. And then when I'm talking to patients, often there's been some sort of stressful event in their life where they can pin down, oh, my IBS symptoms started when I moved or when I got this new job. And it's not that that caused your IBS, but that stress response may have exacerbated your IBS symptoms. And so I think stress plays a really important role, not as the cause, but as a exacerbating factor for IBS.
Yeah. And that's so important for people to hear because, as a dietitian, like doing IBS nutrition for like 15 years, sometimes because, on one hand, I love that when people are feeling unwell, now it actually occurs to them, hey, maybe if I, look into nutrition, I could feel better. Great. I love that for us. But then the corollary is often true that when things seem to be going well and then don't go well, immediately they're like, oh, which food is it? Whereas I can have clients, even low FODMAP, for example, where it seems to be going well for 6 to 8 weeks. And then they say all of a sudden it fell apart. And the first thing I will ask them is like, did you have a big deadline? Was it exams? Like, was there
Hmm.
some sort of stress? Because people don't realize the very real impact on symptoms that a stressful event can have.
Absolutely. And it might not be stress that you think of as like, oh, a stressful event that happened, like a job interview or something like that. It could just be stress on your body. So things like sleep can make a big difference. So if you're just having altered sleep, this is why we get constipated when we travel, or why our gastrointestinal symptoms just feel like a little bit worse when we're not sleeping as well. And there's a lot of research on the relationship with IBS and sleep. So I really promote this idea of taking care of yourself in as many ways as possible. In addition to diet and lifestyle, I think they all play a major role in IBS.
Yeah. I love nutrition, but I'm the first person to say nutrition is never 100% of the solution, particularly in something like this. That is, I feel like IBS is one of those, like, it's the epitome of like the mind body sort of condition and interaction. Like, you
Mhm.
have to take care of your whole self in order for this to feel better.
Absolutely. And I think with any GI condition, because there's such a strong relationship with food, as we were talking about, the temptation is, oh, what can I eat to make things better? But I think, as you said, there's so much more at play here, not just for IBS, but for I think all GI conditions.
Yeah. The amount of DMs that I get that are like, oh, I have IBS. Like, what one food should I eat? Or like, I have like
Hmm.
celiac disease. What one food should I eat? And I was like, no, that's not how it works.
Right. If only that would make our jobs much easier. It'd make my patients' lives much easier. I wish that was true, and unfortunately, it's not.
I know. If only you could prescribe lentils for everything and everything would go away.
Exactly.
So, in the spectrum, particularly with IBS, and it can be a little bit amorphous, can we talk a bit about the symptoms that you use to diagnose IBS? Because what I find in gut health, particularly because it's such a trend now, on one hand, you have people pathologizing everything. They're like, oh, if you're bloated, you must be inflamed or whatever. It's like, no, you could have just
Hmm.
had a big dinner Friday night. Like,
Hmm.
that's
Exactly.
normal. Versus like people also explaining away. They're like, oh, wow, I've been like this for 10 years and I just thought it was my normal. So, what symptoms are a sign that people should talk to you? And when you are diagnosing IBS, what are you looking for?
Yeah, so I will say that IBS is very specific diagnostic criteria. So I think a big myth out there is people get this impression that, well, they couldn't find anything, so they diagnosed me with IBS. And so I really want to emphasize that IBS is a positive diagnosis. And I know we have a lot of work with educating other practitioners as well about this. But specifically for IBS, you need to have abdominal pain. And I have a lot of patients who come in and say, I have IBS, but really what they have is some sort of functional diarrhea or functional constipation, and they have no pain at all. So I think that's a big distinction. And then the pain has to be associated with bowel movements. So either better or worse with bowel movements, and then some sort of change in your bowel movement, whether that's a change in your stool form, so either more diarrhea or more constipation, or the frequency of your bowel movements on the days you have symptoms yourself. So I know it seems that sometimes that your GI doctor is just throwing out this diagnosis of IBS, but know that we have very strict clinical criteria and we should be using that. Um, and then thinking about how to make that diagnosis. And I think a lot of it goes back to the history. So going to detail, I always ask my patients, like, tell me exactly your symptoms. And I'm always stopping them. Okay, what on the days you're having symptoms, what do your bowel movements look like? Really trying to address that criteria. Um, and then reasons to see a doctor. I think any time that your gastrointestinal symptoms are impacting your quality of life, that is a reason to see a doctor. So if you are not able to work, sleep, do the things that you love, eat the food that you love, I think that is plenty of reasons to discuss with a medical professional.
Yeah, I love that. I think, you know, taking the signals that your body is sending you seriously and not explaining them away and go seeing a doc. Like I get so many, questions and emails from folks who are like, "Oh, I have like all of these symptoms." And my first question is, "So what did your doctor say?" And I'll be like, "Oh, well." I'm like, "Oh no." I'm like, turn around, go see your doctor. And in terms of like helping your diagnostic process, do you recommend that people keep like a symptom journal, for example? If that's helpful to you, what do you recommend they document before they see you?
I think that's helpful, like keeping a symptom journal, especially if you're not someone who pays a lot of attention to your symptoms. So I think specific things I would like to know is on the day you're having symptoms, like what are your symptoms? And then what do your bowel movements look like? How frequently are you going? And then what are things that make your symptoms better or worse? And again, this is going back to, are there consistent triggers? And sometimes I'll ask patients like, did that make your symptom worse? And they're like, oh, I never thought about that. But yeah, so I think having that awareness is really helpful and can kind of help you reach a diagnosis a little bit sooner.
Yeah, thank you. That's super helpful. And, I think too, because sometimes I know my memory is really terrible. And then when you get in
Right,
front of it's your time to shine in front of your doc and you're like, your mind goes blank. And then you're like, I guess I'm sort of bloated. And you're like, well, yeah. So I know that
right.
for me, writing everything down can be really, really helpful when I go see my
Yeah.
doc.
And like bringing in questions. I love it when patients have a list and they're like, I wanted to ask you about these specific questions because I'm exactly like you. When I see my own doctor, I'm like, what was it that I wanted to ask you? And I forgot what I did. So my notes app on my phone has been my tool that I always bring with me.
And so, in terms of the diagnostic process, one last thing that I wanted to ask you about is that there can be so many conditions that look like IBS and that have
Hmm.
shared symptoms. And so, what should people be talking about with their doctor? Or what is a doctor looking for in terms of things like bile acid diarrhea or endometriosis? Or if someone, because I know here in Canada, oftentimes what I'm seeing is that GPs are sort of providing the diagnosis of
Hmm.
IBS and not referring on to the gastroenterologist. So they might not be looking for something like bile acid diarrhea. So can we talk a little bit about other conditions that either overlap or mimic symptoms, just so that people can keep them front of mind with their doc?
Yeah, so I think a big symptom that we should always test for is celiac disease. I think that is a really common thing that can mimic IBS in so many ways. It can cause bloating, it can cause diarrhea, it can cause constipation, which I think a lot of people don't connect between celiac. Um, and then So I think that's very easy and should be tested, and that's in our guidelines to test for that. And then I think ruling out inflammatory bowel disease is also an important part of the diagnostic workup for IBS. And so this is actually an inflammatory condition that affects your gastrointestinal tract. And many people get confused because IBS and IBD sound very similar, but they are very different conditions. And this is usually assessed by a stool test, and where you can look for inflammation in the stool. And then I think everyone should get like a basic set of labs if they're having gastrointestinal symptoms. So looking for things like anemia that would cause me to want to explore some other cause of symptoms. Looking at your thyroid, because your thyroid function, either hypo or hyperthyroid, can cause gastrointestinal symptoms in either direction, diarrhea or constipation. And then with endometriosis, this is where I'm like thinking about, do your symptoms relate to your bowel movements? Or what are your symptom triggers? And if that's more of a cyclical nature, if it's related more to your menstrual cycle, then that might kind of raise the suspicion that might be something else that's going on. Or if your symptoms are not really related to your bowel movements. And then with bile acid diarrhea, I typically think of that as if you have any history of gallbladder surgery or gallbladder issues, that would kind of raise the red flag for a bile acid diarrhea as well. So
Awesome.
those are some of the different thought processes that go through my head when seeing someone with IBS. And I think a really important thing is to make sure we're not missing these other conditions. And so making sure you get a good comprehensive evaluation.
Yeah, that's so helpful. And speaking of other conditions, SIBO. So small
Yes.
intestinal bacterial overgrowth, the like giant of gut talk on the
Hmm.
internet. Yeah, we have, on one hand, on one hand, we have a lot of people saying that it's like the number one cause of IBS, and most of IBS is actually SIBO. And then you have what I personally suspect, so I'm curious to hear your opinion on this, that it is vastly overdiagnosed in the population, particularly leading to very restrictive diets and very
Hmm.
unproven, therapies. So yeah, what are your thoughts on SIBO?
So I think SIBO and IBS have a very complicated relationship. And I understand where the confusion comes in because the symptoms are very similar. I think of SIBO, which is small intestinal bacterial overgrowth, more as a symptom than a cause of something. So I think of it as what is happening in your gut that is causing the bacterial overgrowth in the gut. And actually, IBS is something that can cause SIBO because your gut motility is altered in IBS. So that can actually lead to SIBO. Other things to think about are like, is your thyroid abnormal? Is that causing abnormal gut motility? Do you have constipation that's slowing down your colonic motility and then affecting your small intestine? Is there some sort of mechanical blockage? Do you have a like underlying primary motility disorder of your gut? So it's funny because I think a lot of people want SIBO to be the cause, but I actually think SIBO is the symptom that something else is going on, and we need to figure out what that something else is and address that.
I love that. I very much. I don't think I've heard anyone else describe it like that, and I think it's so helpful. Similarly, we could have that conversation about leaky gut and gut barrier dysfunction, because I find it really interesting amongst dietitian colleagues how many dietitian colleagues say gut barrier dysfunction is not actually a real thing when it's very clearly laid out in the scientific literature. And yet we have people getting diagnosed with leaky gut and then similarly being like, ditch gluten, ditch dairy, like ditch everything,
Right,
except for
right.
kale and water. And there you go.
Yeah, exactly. And leaky gut exists, but again, it's a lot of it is like, is it the chicken or the egg? Is leaky gut the cause, or is it the effect of having a condition like IBS or celiac, which we know disrupts your intestinal barrier? And often this is accompanied by someone trying to sell you a supplement to fix your leaky gut, which unfortunately there's just no evidence to support that.
Yeah.
But I do
It's
believe in leaky gut.
good. I believe in science.
Yes.
Yeah. Yeah, thank you for saying. I just think it's such an important distinction of how we talk about, and these are very sexy topics to talk about online, and they get people really interested.
Hmm.
And this idea that it is a phenomenon that occurs, but it's not, oh, you have leaky gut. Leaky gut is the underlying cause of everything that's going on with you, and gluten is causing your leaky gut. So go gluten free for the rest of your life, even though you don't have celiac disease.
Exactly, exactly. I think a lot of things that are on the internet about gut health is this is the one thing that's causing your gut issues, and I have the one solution I'm going to sell you to fix your gut issues. And I wish it was that simple. I wish we could fix everything with one pill or one change, but I think as we talked about, it's very complicated. It requires lifestyle, diet, sometimes medications, and it's not easy, but it can definitely be made better. I want to reassure people out there who are suffering with IBS that we have ways to treat IBS. And it's
Yeah.
not just I'm sorry you have IBS and we can find anything else that's wrong and you just have to live with it, because I don't believe in that either.
Yeah. Let's talk about that a little bit in terms of like treatment pathways. Like what as a physician are you considering for irritable bowel syndrome?
So I think a lot of it goes back to, as we talked about, lifestyle. So I really go into the lifestyle changes and um, modifications that can kind of reduce that overload of physiologic stress on your body. So making sure you get a good sleep, trying to reduce stress in your life, which is obviously easier said than done. Um, and then I really like things like peppermint oil. So I find that that can be really helpful for IBS. The way that works is it's a smooth muscle relaxant. So it can especially address some of that cramping feeling in your gut. And then I think the mainstay of therapy for IBS is trying to normalize your bowel habits. So, if you're constipated, trying to address the constipation, whether that's through medications or diet. And then similarly, if you're having diarrhea, trying to address that either with medications or dietary therapy. Um, for people with really severe symptoms, thinking about a neuromodulator. So these are medications that actually work on the nerves of the gut. They are traditionally thought of as antidepressants, but we use them at lower doses. We also don't use kind of the classic antidepressant like Prozac and Zoloft, SSRIs. Instead, we use something called the tricyclic antidepressant, which doesn't work as a very good antidepressant, but it works very well on the nerves with the gut. And this is some way we use it to kind of restore the communication between the brain and the gut. And a lot of patients have found that very helpful. And that's part of our guidelines for treating IBS.
Yeah, and thank you for mentioning that because I think there can still be a lot of confusion and perhaps even stigma around, well, I went to the doctor for IBS and they want to give me an antidepressant and like not sort of like get why.
Hmm. And sometimes we do a really bad job of explaining what we're trying to treat, and I think it goes back to really understanding the issue with IBS is like a nerve issue, and so the same chemicals that affect depression, anxiety in your brain can also play a big role in your gut, and that's exactly what we're trying to treat. We're not trying to treat your depression. GI doctors don't want to treat your depression. We're not experts there, so we'll leave that to the experts.
Yeah. Maybe this is the perfect point to sort of like mention the whole gut brain serotonin thing, because I mean, one of the stats that I love, just because it's interesting, is how much serotonin your enteric or your gut based nervous
Hmm.
system creates. But again, I find that little nugget of truth is sort of like, bloomed into all sorts of very strange, like, oh, therefore do X, Y, and Z. So, like, what is the role of serotonin in the gut? Like, what's it actually doing in there?
Yeah, so serotonin affects your gut motility, and it can definitely affect your pain processing as well. So sometimes people who start serotonin medications, so things like a selective serotonin reuptake inhibitor, they can experience gastrointestinal symptoms initially related to that, and often the most common one is diarrhea because it's speeding up your gut motility. And so that's something that I always tell my patients if they're coming in with new diarrhea. We always look at their medication list because it might be a medication you're taking that might be causing your new gastrointestinal symptoms. But usually with medications like that, it does tend to get better over time. And if not, there can be modifications made to the medications. But I agree with you. Sometimes people will go, oh, like serotonin is the entire cause. So there are actually two neurotransmitters that I think play a big role in gut signaling. So it's serotonin and then norepinephrine that we don't really talk about. And the tricyclic antidepressants that we use actually target a lot more on this noradrenergic pathway. So it's not just the serotonin that we're trying to target when we're treating IBS and pain in IBS.
Yeah, you're right. We never serotonin gets all the spotlight. We don't talk
Yeah,
about
it's
anything
the trendy
else.
one.
It is the trendy one. But maybe you'll hear on the Allsorts podcast, you will start a new trend and we'll be talking about norepinephrine now.
Exactly. And we'll see all these new gut health videos about that.
Yeah, exactly. For better or for worse.
The
Um,
norepinephrine diet or something like that.
we haven't really talked about low FODMAP yet. So, is low FODMAP like a big part of your practice? Like, what's sort of your approach?
I think by the time patients come to see me, I've often find they've already tried some form of the low FODMAP diet. And I think this goes back to what we talked about with restrictive eating. Often I find they've been on the low FODMAP diet for months and they haven't reintroduced food. So a lot of what I'm trying to do is get them to reintroduce foods, get them to pay attention. I just saw a patient today who was telling me that she's experiencing GI symptoms. Somebody told her to try a low FODMAP diet, but she's also losing weight. And so I told her, okay, we need to take a step back. If you find that something specifically is triggering your symptoms, then yes, like you can avoid that food. But she was so confused. She said she likes to eat beans and that's a big part of her diet. And now with the low FODMAP, she wasn't eating beans. So I think really trying to de-emphasize that over restriction. I do think that the low FODMAP diet works for IBS. There is a lot of data supporting that. And I think it's worthwhile a trial if someone has not been on the low FODMAP diet, but I don't think this is something you should do at home by yourselves. I really recommend working with a GI dietitian like yourself to make sure we do the low FODMAP diet properly, which is the elimination phase where you're cutting out those FODMAPs, and then the reintroduction phase, which I think is the most important part that often gets forgotten, is making sure we're reintroducing those foods so that we can identify what your specific triggers are.
Yeah, it's so true that messaging gets lost time and time again that this is not a permanent
Hmm.
diet. This is a learning diet. We're just trying to isolate the foods, the specific foods, and the specific FODMAPs like fructans or GOS that are triggering your symptoms.
Yes, and it's not a forever diet. I think that's really important. And then the other thing I always warn patients who have been on low FODMAP or some sort of overly restrictive diet for a long time is that when you start to reintroduce foods, you may experience symptoms. And so be prepared for that because your gut just isn't used to certain foods, especially if it's been months, years on a low FODMAP diet. And that does not mean that that is your trigger. You need to kind of give it time as well.
Yeah, something we do, similar to your practice, like so often we are teaching people how to reintroduce, and we call it
Hmm.
fiber training, right? We're like, if you have pulled all of these things out of your diet, that's like you sitting on the couch for 5 years. Like, you can't just go run a marathon tomorrow. Like, you need
Exactly.
to train yourself back into that place. And it doesn't necessarily mean that this food is a no for you forever.
Exactly. And that's why working with a GI dietitian like yourself is so important because you can counsel patients specifically on how to reintroduce foods in a slow, like measured fashion. And okay, try this. And that specific type of food can test this one FODMAP. And I really love that. I think the work you do is amazing.
I also wanted to ask specifically about fibers and whether you use or recommend things like partially hydrolyzed guar gum or psyllium, like what that looks like for you.
Yeah, so I think psyllium has the best evidence for IBS. There's a good amount of evidence that psyllium can help both subtypes of IBS, so both diarrhea and constipation subtypes. I think psyllium is kind of magical in that way. But it's also been helpful not just for normalizing your bowel habits, so treating the diarrhea or the constipation, but it's been shown to like affect global symptoms, so bloating and abdominal discomfort. For patients with diarrhea, sometimes I find that psyllium is a little too much for them. And so in that case, I like something that's more of a like a wheat dextrin type fiber, like benefiber. I think that can kind of help slow things down a little bit better. So that's another fiber that I use in my arsenal. But I think fiber is great, and I take a fiber supplement myself, so
I
I
love me some
I
soluble
love that.
fiber.
Yeah, exactly.
And then after fiber, I feel like, sort of the last like big nut to crack is probiotics. And, the American Gastroenterological Association has recommended discontinuing probiotics in many instances. I, as a dietitian in practice, have found that while they don't work for everyone, there are some clinical strength probiotics that work in my practice. I'm so
Hmm.
curious as to where you're at in this.
Yeah. So typically my approach to probiotics, it's not the first thing that I reach for, but if we've tried a few things, for example, like psyllium, or we've tried some dietary modifications, and somebody is still experiencing symptoms, I think probiotics are a worthwhile try. So I think let's try a probiotic, especially one where there's good evidence behind it and has been clinically studied. We know what's in the probiotic. It's made by a reputable brand. I think it's worthwhile to try. I think the main thing that I'm telling patients is if the probiotics are not helping your symptoms, you don't need to persist and you don't need to take it just because somebody on the internet told you to do so. But I mean, personally, I've had patients where I've had them try probiotics and that they have been very helpful. So I think it's worthwhile a try. And if it's someone comes in and says, my probiotic really helps me, I don't discourage them from continuing it. So I think a very similar practice to yours.
Yeah, and such a balanced approach, right? Like if the other tools in my toolkit are not working and this is available to you, it's like, let's try it. But just as you said, so often people will come to, and if they come to me, they're not feeling well either. So they'll be
Hmm.
like, oh yeah, I've been taking this. I was like, tell me about this probiotic. They'll be like, well, I've been taking it for like 4 years. And I'm like, okay, so is it helping? They're like, I don't know. I'm like, well, because you're here and you still have like, multiple bouts of diarrhea in the morning, it's like, if a probiotic is working for you, you should feel it. Like it should
Hmm.
work for you, and
Hmm.
don't just blindly give them your money hoping that like it's like vitamin D, you just take it
Exactly.
and don't notice.
Exactly. And they're expensive. I think
They're
that's the
so
other thing.
expensive. Yeah.
I like you shouldn't have to pay for something if it's not working or if it's making some for some people it makes things worse. So I think being aware that probiotics can cause bloating, gas, discomfort in many people. So sometimes that's the first thing I take off because they're telling me, "Oh, I've been on this probiotic for a long time." And then we stop the probiotic and that helps. So it everyone's gut is a little bit different and it's not a one size fits all.
Yeah. No, I love that. I'm wondering, in this whole conversation, if there's anything that we haven't touched on that you're like, I really wish people knew this about IBS.
Hmm. I think that there is help out there. I fully understand that a lot of patients, a lot of people that follow me online, they express their frustration because they don't feel that the medical community is very well versed in treating IBS. And I do agree that we need to do a lot more education amongst medical providers, but there are doctors who know how to treat IBS and can help you. So please don't suffer alone, and try to get your resources and learn about IBS from reputable sources and people who understand the evidence, because there's a lot of misinformation out on the internet.
Yeah. And if you're going to follow someone online, following an actual expert like you, a gastroenterologist who treats IBS, like you're the only people like that people should be getting their information from, because there are so many opinions of, I mean, even amongst health professionals. And I wish I could say that we were all going to say the same thing. But that's just not the case. So really making sure that people are going to the source and following you because you're a gastro doc, and making sure that like you're getting the right information.
And I only share things that are supported by evidence. So I try not to mislead people and cause any misinformation out there.
Yeah, I love it. Grateful for it. Okay, so I feel like this is the perfect place to switch gears. A little rapid fire, more getting to know you softball questions. So the first
I'm
one
excited for
is,
this. I gotta sit up and get
yeah,
ready
I'm
for
like,
this.
okay, we're like ready. As a gastroenterologist, what's one daily gut-friendly habit that you have?
I try to walk after every meal because I do think walking improves digestion. I'm actually doing research right now on the effect of step count and IBS symptoms. And there is research out there. I don't have IBS, but I just think that walking is remarkable for your digestive system. But there is data out there that shows that patients who walked a higher step count had improvement in their IBS symptoms. So definitely something that can help pretty much most GI conditions.
And I love that it's so simple. And I would only hope that someone listening to this, these very simple habits like sleep and walking, we tend to greatly underestimate the impact they have on our health. So I hope that people listening, from you, from the doctor being like, oh, she walks after a meal. Okay, that makes sense.
Yeah, and I think don't expect immediate results. I think that's the other thing that's hard is like you're like, well, I walked today and I didn't feel better. I think a lot of it is just part of routine. And make it enjoyable. Put on a podcast, listen to this podcast, and then make it part of your routine.
Yeah, I always say pattern over plate. And I think that goes for things like sleep and water and walking too.
I like that pattern
Yeah.
over plate.
Do you have any like Sunday morning or generally weekend rituals, things that you like to do to reset or restore?
Yeah, so every weekend morning when I'm not working, my husband and I will go to the gym together, and then we go walk by the beach. We live like 20 minutes away from the beach. So our weekend ritual is gym and then beach walk. And then often we go grab bagels, a breakfast burrito, something to
Amazing.
to kind of reset. That's like I look forward to it every weekend.
Living by the beach is one of the greatest privileges. I just feel so restored by the ocean.
Hmm. I
Yeah.
agree.
Okay.
I just feel like it's such a magical place.
It is. Yeah. Okay. Super easy one, or maybe not, but sweet or salty. You can only choose one.
Usually, I've been a sweet person my whole life, but recently I've had more of like a salty flavor for some reason. So all the chips and peanuts in the house.
I'm a salty girl myself, so you're coming over to the savory side. I love it.
Yes.
Your fave comfort food when you're in need of a little comfort.
Oh, peanut butter cups. I know they don't have Trader Joe's in Canada, but the Trader Joe's peanut butter cups are my favorite. And anytime I do a grocery haul, I always like share my Trader Joe's peanut butter cups. So I think that's a good balance between the sweet and salty too.
Oh, it's a perfect balance. Yeah, we don't. Canadians have a real love affair with Trader Joe's, but most of us live pretty close to the US border. So, like, I can get to a Trader Joe's as long as there's no traffic. I can get to a Trader Joe's from my house in 1 hour.
Oh, that's pretty good. How often
Yeah.
do you go?
Not as often as I would like, to be totally honest. But I think that's also a good thing, too, because every time I get to Trader Joe's, I like buy
All the
everything.
snacks.
So, if I
Yes.
was closer, it might be a real problem.
That's fair.
Okay. You are looking to unwind a little bit. Do you choose a book or a podcast?
I wish I could say a book because I really do think I need to read more, but definitely podcasts. I love listening to podcasts. I listen to podcasts while doing the dishes, while going on a walk, while driving to work. So podcasts are my jam.
Amazing. Any faves?
Um, I like true crime podcasts, so I listen to Crime Junkies. That's a favorite of mine. And then I've recently started listening to the Mel Robbins podcast. It's like very inspirational, and I kind of like her raw honesty.
Yeah, I love that. I know there's so many true crime fans. I feel like I'm missing out. It's like all wellness podcasts for me, and then like yeah, inspirational self help.
Self-help ones, yeah.
Yeah,
But I like true crime because it's purely for entertainment. Like there's no educational value in it whatsoever, and sometimes that's what you need.
yeah, it is what you need. Like you don't always have to be learning 24/7.
Exactly.
Dr. Wendi, thank you so much for sharing your knowledge with us. I know IBS is such a huge part of our sort of like well-being, particularly in North America, and I know that people have a lot of questions about it. So I think that this podcast is going to help provide them, if not a lot of answers, a lot of pathways that they can take with their care team.
Oh, thank you so much for having me. IBS is one of my passions. I present on it, I do research on it, so I'm happy to share with everyone and hopefully help a little bit more with your journey with IBS.
Yeah, we so appreciate it.